Neonatal Care, Part 1. Introduction, Transition from Fetus to Newborn, and Arrival of the Newborn. Newborn or neonate care must be tailored to meet the unique needs of the population. Specific terms related to this lecture. Newborn, an infant within the first few hours after birth. Neonate is an infant within the first month after birth. If a newborn needs special support and intervention by trained caregivers, the parents may feel inadequate. So supporting the needs of the newborn and the parents or caregivers is very important. Allow them to be physically close as possible, explain what is being done, and provide details for transport plan to the next level of care. Skilled care interventions to optimize cardiopulmonary function are routinely required in about 1% of deliveries. So 99% of deliveries do not require neonatal resuscitation practices. Approximately 8% of newborns delivered each year weigh less than 5.5 pounds. The most common cause of low birth weight is prematurity. Mortality increases as birth weight and gestational age decrease. In order for the fetus to transition to the outside world, there's actually a process that must occur. So the transition from fetus to newborn, in utero, the fetus receives oxygen from the placenta. Fetal circulation has three major blood flow deviations from that of an adult. You have one, the ductus venosus, you have the foramen ovale, and you have the ductus arteriosus. These shunts begin to close off at birth. So your ductus venosus is right here. This is the venous duct. Your foramen ovale is going to be found right here in between the atrias. So it's an opening from the right atria to the left atria that bypasses the lungs. And then your ductus arteriosus is going to be found up here, and it connects to the aortic arch. Now, once the newborn is delivered, then these ducts actually will close off. So as the fetus is delivered, fetal transition occurs, enabling the newborn to breathe. The first breath is triggered by mild hypoxia and hypercapnia from partial occlusion of the umbilical cord during delivery. Tactile stimulation and cold stress promote early breathing. Pulmonary vascular resistance drops as the lungs fill with air and more blood flows to the lungs. Delays in the decrease of pulmonary pressure can lead to delayed transition, hypoxia, brain injury, or death. There's other causes of delayed transition listed in Table 43-3. Acidosis, hypothermia, pneumonia, hypotension, sepsis, asphyxia at birth, pulmonary hypoplasia, or underdevelopment of the lungs, or respiratory distress syndrome. So on the arrival of the newborn, obtain a patient history and prepare the environment and equipment with any available time. Key questions to help determine resuscitation and needed equipment include the woman's age, the length of the pregnancy, the presence and frequency of contractions, the presence or absence of fetal movements, any pregnancy complications, if the membranes have ruptured and how long ago, what did the fluid look like? Is there a possibility of multiple fetuses? And medications that are currently being taken. At a minimum, to prepare for the arrival of the newborn, you'll need warm, dry blankets, a bulb syringe, 2 small clamps or ties, and a pair of clean scissors. Complications need prompt management, and if we're delivering the newborn in the ambulance, cover the foot of the stretcher with clean, warm blankets for the initial stabilization. After confirming adequate airway, breathing, and pulse rate, place the newborn on the mother's chest. If more extensive resuscitation is necessary, transition the newborn to a second ambulance with a neonatal transport incubator. Suction the mouth, then the nose with a bulb syringe once the head is delivered, only if there is an obstruction and the baby needs it. Keep the newborn at the level of the mother after delivery with the head slightly lower than the body. Clamp the umbilical cord in 2 places and cut the cord between the clamps, but wait 30 seconds, at least 30 seconds. so that you will have delayed cord clamping, which will allow for more blood to circulate into the fetus. If the cord comes out ahead of the newborn, the blood supply to the fetus may be cut off. Relieve pressure on the cord by gently moving the newborn's body off the cord and pushing the cord back. A primary survey of the newborn may be done simultaneously with any treatment interventions. Note the time of the delivery. Monitor the ABCs. Assess airway patency, respiratory rate and effort, tone, pulse rate, and color. Inspect the skin for any abnormalities. Examine the head for symmetry and abnormalities. Examine the eyes of the neonate for irregularities. A newborn who truly cannot open the eyes may have a congenital defect. Watch for abnormal eye movement. Subconjunctival hemorrhages are common and harmless in newborns. Examine for any drainage or ocular discharge. Inspect the newborn's umbilical cord to detect abnormalities and note the presence of any abdominal findings, such as hernias. Newborns are at great risk for hypothermia, so we've got to ensure thermoregulation by making sure they're warm, placing the newborn on pre-warmed towels or radiant warmer, drying the head and body thoroughly, discarding wet towels and covering with a dry towel, and covering the head with a cap. Position the newborn to ensure a patent airway, clear secretions, and assess the respiratory effort. All babies are cyanotic right after birth. If the newborn stays vigorous and begins to turn pink in the first 5 minutes, all we need to do is just maintain ongoing observation and continue to monitor, continue thermoregulation. Want to make sure that we are keeping direct skin-to-skin contact with the mother and keeping the child warm. This concludes part 1.